So welcome everybody this evening to the ABCs of waiting for a liver transplant, a patient roundtable webinar. We're very excited for you guys to be here this evening. Sorry for those of you who were on last week and we had to cancel for tornado warnings, but it's a beautiful sunny cold day here in Cleveland, so I think we'll be good. So welcome to our roundtable webinar for the Northeast Ohio Liver Alliance. I want to just talk about a little bit about who we are. So the Northeast Ohio Liver Alliance is a nonprofit founded in February of 2021 to educate healthcare professionals and lay persons about liver disease, advocate for resources, policy change, and public health interventions that prevent and positively impact liver disease, and also support research and public health interventions that benefit persons living with liver disease. Our mission at the Northeast Ohio Liver Alliance is to promote liver health through education, advocacy, and research to support persons living with liver disease in Northeast Ohio. A special thank you to our team, our staff, our board of directors, and our supporting sponsor, which is Gilead. A few notes before we start. If you have any questions during this presentation, you can put it in the chat and we will address all of those at the end of the session. We'll pick some of them and try to group them if there's similar questions. Feel free to put them in. I'll be keeping tab of all the questions along the way. So our speakers for this evening our first one will be Mary Penko, and then we'll have Maura George and Natalie Crtalic-Lowther, and I will be the moderator and helping to kind of facilitate and answer any questions along the way. So the goals for this evening is one, to discuss the importance of hepatitis A and B vaccination for transplant patients or transplant candidates. Our second goal is to review the necessity of proper nutrition while awaiting transplant. Our third goal is to understand the different organ donors used in transplant. And finally, it will be to discuss dry runs and what are they and why do they occur. So first, we're going to talk about hepatitis A and B vaccinations, and Mary Penko will be presenting on that, and a little bit about Mary. Mary is a recently retired liver transplant coordinator from University Hospitals Medical Center. She has spent over 30 years caring for liver transplant candidates and recipients, and I have had the pleasure of knowing her for 26 of those years. She's been involved for many years with our local liver and transplant organizations, serving as on several boards. She is currently past president of TRIO and is on the education committee for Neola. Mary's enjoying retirement very much and is looking forward to her first grandchild in July of this year. So take it away, Mary.
All right. Welcome, everybody. We're going to talk a little bit about hepatitis A and B vaccinations and why they're important. So the objectives are to give a little overview of hepatitis A and hepatitis B, talk about the risks of hepatitis infections in transplant candidates, the benefits of vaccination against hepatitis A and B, and recommendations for transplant candidates. So let's talk a little bit about the difference between hepatitis A and hepatitis B viruses. Hepatitis A spreads mainly through contaminated food and water, causing usually an acute self-limiting infection. Hepatitis B spreads through blood and body fluids and can cause chronic liver disease. Hepatitis A transmission, it spreads mainly through what's called the fecal-oral route via contaminated food or water sources, which means generally not good hand washing. And when I was preparing for this talk, it reminded me of, I don't know if people were around back in 2003 and remember there was a big hepatitis outbreak from Chi-Chi's restaurants. And it was ultimately found that hepatitis was being spread from green onions. And over 650 confirmed cases of hepatitis A as a result of that. And I believe the Chi-Chi's restaurants, they ultimately filed for bankruptcy. And I think all of those restaurants have closed. I know there's none around us anymore. But that reminded me of hepatitis A and just the importance of hand washing. And hepatitis B spreads through infected blood, sexual contact, and also can be spread from a mother to a child during childbirth. The hepatitis A outcomes. Hepatitis A infection is typically resolves fully without causing any chronic liver damage or lasting health issues. Chronic hepatitis B infection increases chances of developing cirrhosis and liver cancer over time. Individuals with weakened immune systems face heightened health risks from chronic hepatitis B infection. What are the risks of hepatitis infections in transplant candidates? Transplant candidates have increased infection susceptibility. When you have an end-stage organ disease like liver cirrhosis, you have a weakened immune system just from your illness, the poor nutrition and everything that goes along with that chronic illness, making a person more prone to infections such as viruses of hepatitis A and B. Effective infection control is critical to improve transplant outcomes and patient health. Some of the complications from hepatitis infections post-transplant. Immunosuppression after transplant increases a person's vulnerability or their chances of getting a worsened hepatitis infection. Hepatitis infections can cause severe liver damage in transplant recipients. And infections increase the risk of organ rejection and reduce graft survival rates. Risk factors associated with the immunosuppressive. Immunosuppressive therapies weaken the immune defenses to prevent organ rejection, but the balancing of that is that they also reduce a person's ability to fight infections. So that suppressed immunity leads to higher susceptibility to various infections post-transplant. Let's talk about the benefits of vaccination. Vaccines effectively reduce the risk of hepatitis A and B infections, promoting liver health. And vaccination prevents severe liver illness and complications related to hepatitis infections. Protection during the transplant process, the role of vaccination. Vaccination provides essential immunity that safeguards transplant candidates against infections during vulnerable periods. The transplant process increases infection risk due to immunosuppression, making protection critical. Contribution to the overall transplant success and longevity. Vaccination reduces hepatitis-related complications, enhancing patient health after transplant. Vaccination leads to better graft survival by lowering infection risks post-transplant. Patients experience improved long-term outcomes and reduced infection rates after vaccination. Recommendations for transplant candidates. The optimal vaccination timing. Vaccines are best given prior to transplant to ensure effective immunity against hepatitis A and B. There are various formulations exist for hepatitis A and B vaccines tailored to different patient needs and conditions. And they are generally a series of vaccines. It's not just one. There is a combination one with A and B if someone needs protection from both of those. And they're usually either a series of 2 or 3 vaccinations. Vaccination schedules depend on patient-specific factors such as age, health status, and risk exposure. Guidelines from medical authorities. Medical authorities recommend hepatitis A and B vaccination for transplant candidates lacking immunity. Transplant programs will be testing you for the hepatitis viruses and can let you know if you would benefit from vaccination and what type of a vaccine you should get. Ensuring immunity to hepatitis A and B before transplantation improves patient safety and outcomes. And transplant programs are now required to document if a patient has been vaccinated for hepatitis B. Monitoring and follow-up after vaccination. Antibody levels can be monitored after someone gets a vaccination to help confirm that they have protective immunity. And booster doses may be required to maintain immunity, particularly for immunocompromised patients. In conclusion, vaccination against hepatitis A and B prevents infection-related complications in the transplant candidates. Immunization improves transplant outcomes and increases patient survival rates. And adherence to vaccination protocols is essential for effective transplant patient management.
Excellent. Thank you, Mary.
Mhm.
So our next talk will be on dry runs, and that will be presented by Maura George. And Maura's been a liver transplant coordinator at the Cleveland Clinic for 7 years. She works with patients being evaluated for transplant, patients who are on the transplant waiting list, and now she works with all living liver donors. She recently accepted a position as the clinic manager of the transplant team. She loves working with and educating patients and welcomes you to this webinar. Thanks, Maura.
Thanks, Ashley. Good evening, everybody. Thank you so much for being with us. So I wanted to talk a little bit about dry runs, something that you probably have heard about when you were being evaluated or when you got on the list, but let's kind of do a little bit of a deep dive. So when an organ offer falls through, we call it a dry run. You may be called with an offer for transplant only to be discharged from the hospital or maybe not even admitted, staying at home, if the quality of the liver from the donor is insufficient. Patients can feel very unprepared for these dry runs, and they find the experience both mysterious and frustrating, which can really negatively impact your mental health. So it's kind of why we wanted to talk about this today with you. Let's talk a little bit about how organ evaluation actually works. So when an organ offer comes through, the surgeon is kind of going to look at that offer and look at the donor, but just on paper. The offer then will come to you before the surgeon actually sees the organ physically. Once the surgeon gets to see the organ, they can assess the organ quality in real time. And testing and time can start to reveal some unexpected issues. If the organ is unsafe, the team will decline it to protect you. So let's talk a little bit about why organ offers sometimes don't proceed. The liver may not function as expected upon closer evaluation. Some of those reasons could be that the donor health findings may change. The donor may not pass away within a certain time frame. The liver may have a finding that may not be suitable for transplant. And, now many transplant centers are able to put these livers on a pump, and the pump kind of makes it think the liver is still in the body. And we're able to run diagnostic tests on that organ once it's out of the donor's body. We're able to monitor that liver to see if it's going to be viable. And sometimes those livers don't perform well. And so if that's the case, we will decline that liver even after it's on the pump. This can feel very difficult. Because waiting for an organ offer can be emotionally exhausting. Sometimes you're waiting for months or even up to a year or more. And this offer creates hope. Losing it can be very disappointing and frustrating. Remember that these feelings, though, are normal and expected. Sometimes you actually have to wait for hours to even know if the liver's viable. You could get a call tonight and you might not know if this liver is going to actually be viable until maybe even the next day. And also, I want to kind of stress this because we don't talk about it a lot. We say dry run, but you may have multiple dry runs. Just because you get one doesn't mean that the next liver is not going to be a dry run. So remember, you can have multiple dry runs, and this can really be frustrating. I just want to reiterate that you should be reaching out to your transplant social worker or your nurse coordinator if you do need to talk. We have resources available. We can get you in touch with people who have gone through this. Lots of people went through dry runs, but it's happening to you. So it can really, really feel very frustrating. What dry run does not mean. It does not mean that you've lost your chance. Remember, you will remain on the transplant waiting list in the same position. Your MELD score doesn't change just because you get a dry run. It also will not delay future offers, and it doesn't mean that you can't be disappointed if you get a dry run. So some reasons to stay positive. Remember that your team is always going to advocate for your safety first. So a declined organ offer just means a better one is ahead. Many patients receive another offer soon after a dry run. It's also a chance to assess your feelings about the transplant and the surgery, and it's a really good way to know if you're prepared. You may get an offer, and you're thinking like, I'm not ready for this. I didn't expect this offer was going to come so soon, or I don't have plan in place to be away from my house for a long period of time. Take the opportunity of having a dry run to kind of assess how you're feeling about the actual surgery, about being away from home for an extended amount of time in the hospital. And always remember that your transplant team is working hard to get you the best liver possible. If it's not good, they're not going to give it to you. What can you do? Well, you have to be patient, and be ready for next time. So remember, keep your phone available. Make sure it's charged. Make sure it's near you at all times, that you're answering phone calls from numbers you don't know or block numbers, and stay ready for the call. It can happen at any time, day or night. Remember to tell your team, your transplant coordinator, about any health changes right away. So if you get hospitalized, or if you need a blood transfusion, something like that, make sure your team's aware. And have your bag packed. Be ready to leave your house within about 30 minutes, because sometimes you might have to leave that soon. Sometimes you might have to remain at home for a while. But just have a plan in place. Have a plan in place for your kids, your pets, your plants, etc. Just make sure you're ready to go when you do get that call. And again, remember, if you do have questions, we'd love you to reach out to your transplant team if you need more information. We're always available. You always have a resource. And if you do start to, feel frustrated, feel down, feel defeated because you're getting these dry runs, please reach out. We can help you. We can have you talk to other people who have gone through this. We just want to make sure that you understand that dry runs can happen. They are a normal part of the waiting process. They are an unfortunate part of the waiting process, but we understand that it is also very frustrating. So reach out if you have any questions or you need anything from us.
Excellent. Thank you, Maura. That was amazing. So our next topic is going to be on nutrition. And I'd like to introduce you to Natalie Crtalic-Lowther. She's a registered dietitian at the Cleveland Clinic, and I think this topic is really important, especially for pre and post-transplant patients. I think nutrition is something that we struggle with, and she has some great information for you this evening.
Thank you guys for having me. Why nutrition matters in the transplant process. Something called malnutrition is very common in patients with advanced liver disease. Malnutrition comes in all shapes and sizes. It doesn't always appear as we may think it does. But malnutrition and not getting enough of the correct nutrition leads to muscle wasting or sarcopenia, which is very common, as well as weakness and frailty. When we have poor nutrition, that negatively impacts your transplant outcomes, including your survival rates after transplant. So it's really important to make sure that we're optimizing your nutrition status in the pre-transplant stage so that you can be successful post-transplant. Having adequate nutrition prior to transplant is essential for maintaining your strength, preparing your body for surgery, and getting the best outcomes possible. The goals of pre-transplant nutrition are to prevent further muscle and nutrient loss, reduce risk of infections and complications post-surgery, correct vitamin and mineral deficiencies, which are really common in the liver population, and improve your recovery after you get your transplant. I want to talk about nutrient deficiencies just for 2 seconds while we have this slide still up. Vitamin and nutrient deficiencies are really common, specifically fat-soluble vitamins, vitamin D, A, E, and K, which are generally stored in the liver, which is why those end up with deficiencies. If you're ever worried about any vitamin deficiencies, you can always ask your doctors to draw some labs so that we can evaluate those vitamin and minerals and see if we need to start supplementing or if you need a dietitian to recommend you some foods that can help boost that up in your diet regularly. B vitamins are also commonly seen as deficient, especially with alcohol-associated liver disease, as well as minerals like zinc, magnesium, iron, and calcium. And these are all things that can make you feel better if they're deficient, and we start to supplement them with either food or vitamin and mineral supplements. Protein is extremely important, probably the most important nutrient when it comes or macronutrient when it comes to nutrition. Most patients do not get enough protein prior to transplant, and this directly relates to malnutrition specifically. There are many sources of protein. Animal sources of protein are commonly known chicken, fish, beef, eggs, dairy is another source. And there's also many plant sources of protein too. So if you're, vegetarian, vegan, or you just don't really like meat, you can get protein from things like lentils, beans, tofu, and lots of vegetables and other plant-based foods as well. We always want to prioritize whole foods as often as we can, but there's nothing wrong with supplementing with protein shakes and protein supplements and things like that to help support your needs if your appetite is poor and you're just really struggling to get in the a right amount of protein for you with food sources. Um, at one point in time, we thought that protein may need to be reduced in patients that have kidney disease or rising ammonia levels. The ammonia levels is not something that we limit protein with anymore. But if you do have kidney dysfunction of any kind, we always recommend individualized and personalized review from a dietitian, just so we can make sure that you have the right amount of protein and you know how much you need. Protein helps maintain muscle mass and prevent muscle wasting, so it's super, super crucial. Again, dietitians, we're the ones that calculate these needs. So we can figure out how much you need and give you an exact number so you can count it up between your meals and your protein shakes and whatever else you're eating in your diet to make sure that you're getting the correct amount and not too little. Because protein really should not be restricted in the liver population. It should also be distributed evenly throughout the day. I see a lot of patients that will tell me they maybe only eat once a day or twice a day. And for the liver population, it's really important that you guys eat like 3 to 5 small meals and snacks throughout the day, just to make sure that you're getting even protein distribution throughout the day so your body can synthesize it and use it to its maximum potential. Getting enough calories is also something that's really important. So when you have liver disease, you have increased energy needs because the liver no longer effectively stores energy the correct way, and that leads the body to sometimes break down muscle for fuel. So we really want to make sure that we're getting enough calories in to support our needs and getting enough protein so that we can refuel our muscles if any protein is being broken down and used in a different way than it's supposed to. Chronic inflammation also increases metabolic demand, so that may make your resting energy expenditure higher than normal. Some tips, again, to get enough calories in is eating frequently. Try to eat on a regular schedule, even if you're not feeling super hungry. Small meals, and by small meals, I don't mean like a whole, meatloaf, potatoes, and carrots. A small meal could just be like some crackers and some cheese, or peanut butter and a banana. More like snack type of foods. But just getting your body used to having food regularly is super important. We don't recommend you skip meals. And again, we recommend adding protein shakes, smoothies, supplements, anything else in to help support your intake. Liquids digest faster than solids. So if you feel like you're really full, like you have a lot of like bloating, fullness in your stomach area, and that's preventing you from wanting to eat more, focusing on liquids, like balanced smoothies with a protein source, yogurts, things that digest quicker are great options. Try to avoid empty calories like sodas, candies, until you've actually had enough nutritious food in for the day, so that you're getting more nutrient-dense foods instead of calorie-dense foods without the nutrition. That's because it just takes up, if your soda just takes up space in your stomach, especially if you're getting really full, easy, things like that, just take up a lot of space and don't provide what we really need. And also, you want to avoid foods with a lot of salt in them. Drinks too, things like Gatorade, that will have you retain water, may not make you feel as great. Salt and fluids is my last big topic of conversation here. Most liver patients need to limit their salt and or sodium intake to 1,500 to 2,000 milligrams per day. I use this range because having less than 1,500 milligrams per day is usually a little too little. You do need sodium as a natural electrolyte in your body to help regulate processes. So you need some, but the average American consumes about 4,000 milligrams of sodium per day. So cutting back to 2,000 from the recommended 2,300 is a really good spot to be at, but we don't want to go so low that we have no salt in your body because salt is important with your heart and keeping your electrolytes regulated. But we want to reduce added salts and added processed foods, restaurant foods, things that have copious amounts of salt in them, and that will reduce your fluid buildup and swelling. Ascites is something that's common in the liver population, and you may know that as fluid holding in your abdomen or your belly. Sometimes it's treated with diuretics, which are water pills, and fluid restrictions, meaning that your doctor may tell you not to drink so much water. Your doctor may even drain your stomach if you have too much fluid building up inside. And limiting the salt prevents those things, the fluid from building up so fast and from needing those extra interventions. You want to aim for about 64 to 80 ounces of caffeine-free fluids every day. Caffeine containing fluids leave your body too quick, so we want to make sure that caffeine-free, you're able to use that water a little bit better. And then it's very important if your doctor does tell you at some point in time that you need to restrict your fluids, that you do listen to them. You can always talk with a dietitian and they can help you determine what counts as a fluid, and help you figure out the best way to consume your fluids and your fluid-rich foods throughout the day. Consequences of poor nutrition in the transplant process, it increases your risk of mortality, complications after surgery, and time on the transplant wait list, which I don't think anyone wants to spend any more time on the wait list than absolutely possible. So to improve our outcomes for the best, we really want to get good nutrition in. Frailty, longer recovery times are also not desirable. So just keep these things in mind. So we want you to stay strong before transplant. Focus on eating plenty of protein, enough calories, and eating frequently. And early interventions are really the best. So we want to keep your strength up, have the best outcomes and the best recovery. So please reach out to your doctors and have them set you up with a dietitian if you need some individualized help in improving your nutrition. And be very wary of what you hear and what you see on the internet. Please ask the professionals before you start doing things that you see online, just to make sure that those things are really the best thing for you, especially with supplements and things like that. Most of it is too good to be true, and you don't want it to cause any more damage to your liver or your body in the process. Thank you.
Thanks, Natalie. That was amazing. And we have lots of questions for you later. So
Oh, wow.
hang in there, hang in there. And our last topic goes back to Maura, and she's going to be talking about the different types of organ donors.
All right, thank you. Here we go again. I wanted to choose this subject for our webinar today because I think things can get a little muddy, especially while you're, kind of getting evaluated for transplant. And, we talk about it a lot, and then maybe you're on the list and you forget. And then suddenly you get an organ offer in the middle of the night and you have to make a decision. So let's talk a little bit about the two kind of common organ offers and donors that you may get. a DBD and a DCD liver. So let's talk a little bit about understanding what those letters mean, and kind of when you're looking to make a decision, what's best for you. These organ offers can come quickly. They can come in the middle of the night, and it might be very stressful, especially because, you have to say, yes or no. So this presentation is going to talk about donation after brain death, which is a DBD liver offer, and donation after circulatory death, which is DCD. Understanding benefits and risks can reduce the fear of the unknown. There's no universally right or wrong offer. It's really only what is safest and best for you at that moment based on your goals and your comfort risks. So let's talk a little bit more about these so that you can be a little more comfortable and know what kind of questions to ask when your offer does come through. Remember, I talked about in the previous slides that every offer is going to be reviewed by an experienced transplant team. So their role is to make sure they're looking at these organs and making sure they're going to offer you the best one. Your role is to know the basics, ask questions, and share your preferences with your team. So the best decision can be made to keep the focus on getting you safely back to living your life. Okay, what is DBD? Remember, it's donation after brain death. What does that mean? It means the donor is brain dead, but the heart is still beating. So that means the liver is still getting blood, which means it's remaining well oxygenated until it's recovered from the body. So the DBD livers then generally have lower risk of early dysfunction and graft loss. Graft means liver in this case, so your new liver. And there's a lower likelihood of needing a retransplant compared with getting a DCD liver in some groups. And what is DCD? Remember, it's donation after circulatory death. So what does that mean? That means the donor's heart stops after they take them off of life support. So the organs are recovered quickly after the circulation stop, but there's a short period where the blood is not flowing into that liver, meaning it loses some oxygen in the time between when the patient passes away and when the time the organ actually comes out of the body. Let's look at some survival outcomes for DCD. So overall, 1 year patient survival is relatively high. It's about 94.5%. Some populations do show higher graft loss risk with a DCD. And remember, I talked in the previous slide deck about the pumped livers. So NRP is a pumped liver. So a DCD liver that's pumped can actually yield comparable outcomes to a DBD. So why even consider a DCD liver? First of all, it's shorter waiting time. Natalie talked about it in her slide. I'm talking about it in my slides. You want to be on the waiting list for as little time as possible. And the DCD expands the donor pool. You can also get transplanted while you're stronger. The higher your MELD score gets, the sicker you get. So if your MELD score is relatively low, you may not get an offer for a DBD liver. You may be waiting. And waiting for DBDs only can just increase how long you're waiting on that list. DCD livers can face slower early recovery. You may be in the hospital for a little bit longer. It might take a little bit longer to start functioning, but actually long-term outcomes can be very similar to the DBDs when it's matched well. So that kind of can enable a sooner transplant for you. And many transplant centers worldwide have better preservation techniques, surgical techniques, and monitoring. So we can get results near DBD in selected patients. So again, we're putting that DCD liver on a pump. We're conducting tests. We can see if it's viable. So we can find out, is this liver this DCD liver going to function well, and it can function nearly as well as a DBD. Let's look at some outcomes and recoveries. So DBD versus DCD. So early after transplant, a DBD liver kind of wakes up faster. I kind of mentioned that earlier, which means a smoother start to recovery. And DCD livers may have more early hurdles, so slower lab improvement, longer hospital stays, but actually long-term results can be very similar in well-matched patients. Success really depends on careful donor selection, experienced teams, and close follow-up, not only the donor type. So remember that the surgeons and the physicians are looking at these donors very, very carefully. We have experienced teams that are going to take care of you after transplant, and they're going to be monitoring you for the rest of your life. I also want to remind you that your transplant team is going to do a lot of the work to make sure this is a good liver and it's going to work for you, but you have to do a little bit of the work yourself by making sure that you're taking your medications the right way to prevent this liver from rejecting. And you want to make sure that you're going to the labs and make sure you're going to all of your appointments. So we're going to do all of the work in the beginning, and ultimately the outcome is going to be based on your engagement with this new liver. The decision, DBD versus DCD, should be weighed against the waiting list risk. So delaying and waiting for a DBD offer may increase your complications if your disease process is getting worse. So the longer you wait, the sicker you can become. So you have to kind of think, you want a shorter wait and maybe go for the DCD? Do you have time to wait and maybe wait for this DBD? Every organ, DCD or DBD, is going to be looked at, again, very closely by your team. They're going to be looking at the donor's age, their medical history, the cause of death, and their labs. And of course, they're going to be looking at the image of the liver, so a CT scan, an MRI, whatever they can get. The surgeons and the hepatologists are going to discuss concerns using their own experience and evidence. We always are practicing medicine using evidence-based. Any organ that doesn't meet our standards will be declined. And that's kind of ties in with my other presentation about dry runs. If it's not going to work for you, we're not going to give it to you. Let's talk about your role. We talked kind of about your what you need to know when making the decision, but how do you make that decision if you don't ask questions? Knowing the basics of DBD and DCD, like what I talked about tonight, can help you compare these offers. That helps you understand your recovery, and it focuses on the risks that matter most to you. Remember that it is your right to decline any offer. Any organ offer that comes through, it is your right to say no. Before you say no, though, I do want you to kind of talk to your transplant specialist about how turning down an offer could affect timing and future opportunities. And we expect these questions and we welcome these questions. We want you to make a decision that is right for you, because shared decision-making balances the medical evidence that our physicians use with your values and what you want. So whether you want the soonest transplant or you prefer to wait for certain offers, that's going to kind of be a combination of what your physicians think versus what you really want. So be open about asking questions. You can always reach out to your transplant coordinator if you're like, well, I don't have a connection to my surgeon. I only met him or her that one time a couple of months ago. That's okay. We can help you. The transplant coordinators can help you get in touch with your surgeons and can help answer some of these questions for you. It's what we're here for. Thank you very much for joining me today. I think Ashley is going to take it from here with our questions.
Yes. So those were all great presentations. This has been amazing. So you can add in some more questions if you want. I'm going to kind of pick a few that kind of relate to this particular presentations and presenters. So I want to start with the vaccines and hepatitis A and B vaccines. We have a couple questions. The first one that came through is it recommended for family members to be vaccinated as well?
I would say yes, it's always a good idea for people to be vaccinated when they can be vaccinated. So yes, and they can talk to their physicians about whether they need to be tested in order to see if they need it. If they know they never had the vaccines, then they can certainly be vaccinated.
Yeah. And along those lines, there were a couple questions regarding organs and organ donation and hepatitis C. Somebody's been told to consider a donor liver even if it has hepatitis C because of the curative therapies. Is that common? And is that affected in the liver? What are those outcomes like in terms of those that might be coming with hepatitis C?
I do think that yes, hepatitis C organs are being used a lot now, probably more than ever because we've got the ability to treat the hepatitis C. So I think it's as Maura was talking about the advantage of sometimes taking an organ that's a DCD because you can get it sooner. Hepatitis C is working the same way because we will treat all the patients that take that organ with the medications, and it's generally 12 weeks of therapy, tolerated very well now for patients. So I think it is something that we're definitely doing a lot of, and it is very common for patients to take that organ in order to get their transplant sooner.
Yeah, that's great. Let's see. This is for Natalie. So, I think you kind of touched on this, but if you can just review how much protein should patients be aiming for? Is it individual? Is there kind of like a global idea of how much protein they should have? And with that, I think you said protein shakes and supplements are helpful, especially when you might have ascites and, lots of other things that, create some problems with digestion. So you can touch on that, and then I have a couple others.
Yes, I know. I saw you guys asked such good questions. I love these. So how much protein should you be aiming for? It's individualized. It's different from person to person. How I calculate it is I typically look at a patient's body weight in kilograms, not pounds, kilograms. And I will multiply it by a factor depending on the severity of the liver disease, what other comorbidities are at play. It's usually somewhere between 1 and 1.5 grams per kilogram of current body weight, but it varies from person to person. So if you're wondering how much protein you specifically need, please see myself or another dietitian, and we can go over your specific needs based on your individual situation.
So I think this was an interesting question as well, is can an obese patient be malnourished?
Yes, and I actually kind of like sort of alluded to that at the beginning when I was talking about malnutrition and how it comes in like all shapes and sizes, and it may look different than it appears. Yes, a BMI of obesity, you very well anybody of any shape and size can be malnourished because malnourished just means that you're not getting the proper nutrition in, and it actually hides very well, in people that are of obese BMI, because you have a lot of extra weight on you. It's the muscle, the lack of muscle or underneath the weight and the skin can hide. So we do a lot of physical exams on our patients where we'll take a look, we'll actually touch them and palpate their muscles, and try to see if we can separate the muscle and the fat in their arms and things like that. It's very gentle, but it's, we're kind of seeing and trying to feel if we feel enough there. We also do body scans to determine, what percentage of your body is fat, what percentage of the body is water, how much muscle do you have, and compare that to standards to see, what it looks like inside your body.
Excellent. And then somebody asked, sleep is often very erratic in a lot of
Mhm.
these liver transplant patients. So
Sure.
how can you get those small meals when you're sleeping during the day and up all night? What would be your
Well,
recommendation?
if you're sleeping during the day and you're up all night, the night is now your day. So when you're awake, you should be eating. Whenever you can, get some food in. Just because it may be like not the traditional time that we eat breakfast, lunch, and dinner doesn't mean that it can't be your time to eat breakfast, lunch, and dinner and miscellaneous snacks.
Hmm. Yeah. And either of you, one of the three, can you please explain the relationship between beef protein and the potential for hepatic encephalopathy? Is that even a real thing?
Yeah, no, it is. There was some research that showed, I think that if I'm remembering correctly, I think that beef can increase ammonia levels up to like 20 to 30% higher than non-meat sources. So like plant-based sources of protein. Plant-based sources of protein are a lot safer for anyone that has kidney disease as well as liver disease because it's gentler on the kidneys. It also produces less ammonia. Dairy also produces less ammonia. On my slide, I don't know if anybody caught that, but when I was talking about the protein sources, I did make a note that next to the beef should only be consumed maybe once a week, and it should always be a lean source. That's because too much beef can be a contributor. We just don't want, there's so many reasons not to eat a ton of red meat. So definitely want to keep that limited.
Excellent. And the last question, what if my sodium concentration is low? Doesn't that mean I need to take in more salt?
This is my favorite
It's the favorite
question.
question. It's the
This is
question
my
we
favorite
all get
question. Yes, well, I
all the
want to make sure people
time.
understand this right, that like your concentration, like your sodium concentration in your blood is not necessarily related to the sodium that you're taking in. Your blood has to maintain like a homeostasis, a balance all the time for your electrolytes. So if you're consuming copious amounts of sodium, what your body is doing, it's taking the sodium out of the blood and it's throwing it elsewhere into your body, which tends to be when people have low sodium levels. It's because they're holding on to water, they're having water retention, or their fluid balance issues, kidney problems. Sometimes, I mean, if you're like a crazy intense athlete and you're sweating a ton, you can lose sodium through your skin too if it's temperature's hot, if you're sweating a lot. But most of the time, it's a fluid imbalance problem, not a you need to eat more sodium problem. So definitely, if you're worried about those sodium levels, definitely talk with your doctor before you start taking more salt in, because that's usually not the case. I would say a majority of the time you don't need more salt.
It's very true. All right, Mara, you're up. So, or I mean, either Mara or Mary.
Oh,
So,
there's one more in here for me. Can I
oh,
answer this last
oh
one
yeah,
real
sure, sure,
quick?
sure. Yeah, I didn't
So I
even
just
see
saw
it.
somebody pop one in about gas from
Oh, yes,
legumes
I
and
see that
plant
now.
protein. Yes, it can be uncomfortable, and there are things that you can do to minimize this. If you are eating beans, especially if you're making them yourself, you can soak them and rinse them, and that removes some of those compounds that produce gas. There's also over-the-counter things like Gas-X and Beano, as long as you're checking with your doctor to make sure those don't interact with any of your medications. Those are great sources. And tofu typically doesn't produce gas. That's a plant-based protein as well that can be used in many, many ways. So that's something else, another plant-based source.
Perfect.
Thank you.
Awesome.
Okay.
So,
Oh,
Mara,
I
there's
see
a
a
few.
lot of good
Oh,
questions.
there you go. Why don't you just go right through them?
I'm super
So what is
excited.
the MELD score? In simple
Okay.
terms, why does it matter? What does it mean? Why do we use it?
Yep. So MELD score, and I'm sorry if you didn't, I probably should have explained it when I was talking about it. MELD, MELD, is a number, as you know, between 6 and 40. And it is based on your labs. 6 is a normal liver, 40 is a very sick liver. By the way, MELD is the model for end-stage liver disease. So everybody loves a little, knowledge on that. So we take your labs. We're looking at your sodium lab, your creatinine, which is kind of an indication of how your kidneys are doing, your total bilirubin, which can kind of show us how your liver is doing, and your INR, which is how quickly or how slowly your blood is clotting. And it factors in a couple of other things. If you're on dialysis, your gender, etc., and it can calculate a number between 6 and 40. 6 is a normal liver, 40 is a sick liver. The higher the MELD score, the higher you are on the transplant waiting list. Okay. So MELDs typically, between 30 and 40 are going to get offers for livers relatively quickly. But when your MELD score is low, like a 12, for instance, you'll be waiting on the waiting list a lot longer, which is why we, are talking about these different kind of offers that you could potentially get with a lower MELD score. Sometimes you may be sicker than what your MELD is showing. Your labs look decent, but you're not feeling decent. You're getting, your belly tapped to get the fluid off. You're exhausted. You have the confusion that comes with liver disease. Those are all symptoms of liver disease that the MELD score cannot capture. So just because your MELD's not high doesn't mean you're not feeling sick.
What one piece of advice would you give every patient on day one of being listed?
That is such a good question.
Yeah, that's a good one.
I love that question. The advice that I give, I'm a very positive person, and I'm always trying to keep this positivity going for everybody. So I always say, congratulations and good luck, and you can get a call at any time. So I always want to make sure that people know you're on the list now. That gives you a chance. It gives you a chance to get a call any time of day or night, and it could happen before you know it. What about you, Mary?
Yeah, that's what I was going to say is be ready.
Yep.
Once you're on that list, I mean, some people think, oh, I got a low score, and then all of a sudden they get a call. So you
Yep.
want to be ready and kind of have those things like Maura talked about earlier. Have those plans made even while you're going through the evaluation. What are we going to do if we live 2 hours from where we need to go? How are we going to get there? Who's taking us? Just having thinking about all those plans, for being ready for when it happens.
Absolutely.
Yeah. Yeah.
Are there ways patients can advocate for themselves while waiting? Absolutely. Absolutely. I love when patients advocate for themselves. A couple things I will say. We talked a lot about deceased donors today. We also, many centers do living liver donors. So I will say, if you can advocate for yourself by telling your story, a lot of people will hear it, whether you're using social media or you're using, any kind of in-person social groups like clubs or churches, etc. Tell your story. When people hear your story, they want to help, and you can potentially find a living donor. You also want to advocate for yourself when you know something's wrong. I always say, yourself best. If you think something is wrong, you have to advocate and say, I know that I'm not feeling right, and I haven't felt like this before, and something's wrong. And you have a nurse you can talk to at all times. Once you're in the transplant world, you have a resource, and that is your transplant coordinator. 24 hours a day, people are going to be answering that phone. You call them. It's not a bother. We're here to help. It is the reason why we have jobs, is to help you. So I would say always, 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 if you think something's wrong, say it. It's never a bother. Do I really have a choice to decline DCD? It is your option to say no. It's your health. It's your surgery. It is your right to say no if you do not want an offer. You have to consider what saying no means, though, right? Okay, say your MELD score is low, you're feeling okay, and you are about to go to Florida for a vacation, and you're feeling okay, and you get an offer right before you leave. Okay, maybe now is not the time, but saying no to that offer now, does it jeopardize your chance of getting an offer down the line? You may have to wait longer. So you have to think about what you need. Are you really feeling sick? Can you not really wait? Then maybe say yes to the DCD, but know why a DCD is a little bit of a higher risk than a DBD. I hope that answers that question. And I think these are terrific slides and presentations. Thank you for being a part of this evening tonight.
Yes, this was amazing.
This was wonderful. I'm really glad that everyone was here.
Yes.
Excellent. All right. Well, I think we're all set. Thank you for joining us this evening. We had beautiful weather, no tornadoes, and we're good to go.
Thanks,
Thanks,
everybody.
See you at the
everyone.
next one.
Thank you.